Universal Definition, Staging, and Comprehensive Clinical Matrix of Advanced Edition. I'm Dr. Fernandez, and today we're diving into the universal definition of heart failure, precise staging, the 4 pillars of therapy, and 20 real-world cases that will sharpen your clinical matrix forever. This isn't a dry lecture material. This is the blueprint for saving lives and prevention progression. Grab your notes, hit that like button if you're ready to level up, and let's get into it. Precision staging and pharmacotherapeutic protocol starts now. The universal definition of heart failure, the clinical syndrome. Heart failure isn't just a low ejection fraction or some number on an echo. According to the 2021 universal definition, heart failure is a clinical syndrome, a symptomatic state caused by structural or functional cardiac abnormalities. The key is a 2-factor requirement. You need symptoms and/or signs: dyspnea on insertion, fatigue, orthopnea, edema, rails, elevated GBP. Objective evidence. You need an objective evidence of cardiac structural or function abnormality. Think LVEF less than 50%, left ventricular hypertrophy, left atrial enlargement, and corroboration with elevated natriuretic peptides or objective signs of pulmonary systemic congestion on imaging or exam. This definition keep us honest. No more diagnosing heart failure based on symptoms alone or echo alone. Is rigorous and it catches patients earlier. Biomarkers rigor, BNP and NT-proBNP. Biomarkers are your best friend in the heart failure diagnostic toolkit. A standard threshold. A BNP greater than 100 in acute settings, greater than 35 for chronic, NT-proBNP greater than 300 acute and greater than 135 in chronic. But here's the nuance: obesity discount these levels because adipose tissue clears natriuretic peptides faster. For BMI greater than 30, many experts lower the rule-out threshold roughly by 50% in practice, though exact cutoff vary by study. Always interpret in context. In atrial fibrillation, levels run higher, so triple the threshold roughly to preserve specificity. Bottom line, don't ignore a mildly elevated BNP in an obese patient with dyspnea. It might still mean heart failure. The ACC/AHA staging system, the permanent label for heart failure. Stage A, at risk, which is the at-risk stage: hypertension, diabetes, obesity, coronary disease, but no structural heart disease or symptoms yet. The stage B, also known as pre-heart failure stage, which encompasses structural changes, LVH, reduced EF, and normal biomarkers, but no symptoms. Stage C, or the symptomatic heart failure stage, current or previous symptoms with a structural heart disease. Stage D, advanced refractory heart failure, symptoms persist despite optimal therapy, may need advanced intervention. Crucial point: once you're a stage, you stay in that stage for life, even if you feel great later. It is like a tattoo on the chart. Prevention in A and B is everything to prevent going to stage C or D. NYHA functional classification, the daily snapshot. NYHA is the daily functional snapshot, how the patient feels right now. Class 1 NYHA, the patient has no limitation. The Class 2, slight limitations, ordinary activity cause symptoms. Class 3 NYHA, marked limitation, less than ordinary activity cause symptoms. Class 4, symptoms are rest or with minimal activity. The beautiful thing, NYHA can improve dramatically with treatment from stage 4 to stage 1. But remember, you can go from stage 4 to stage 1 in NYHA. Yet, if you were stage C, you stay C forever. Staging is a disease trajectory. NYHA, today's performance. Classification by ejection fraction. We classify heart failure with LVEF because therapies differ. Heart failure with reduced EF less or equal to 40% is the classical reduce. And you have to use the 4 pillars of medication. The heart failure with mild reduced EF 41 to 49%. Mild reduced SGLT2 inhibitor has strong data. Others are reasonable. Heart failure with preserved EF greater than 50 or equal to 50% is a preserved focus on comorbidities, SGLT2 inhibitors, and now GLP-1RAs in the obese patients. Heart failure with improved EF, a new definition, previously less or equal to 40% EF, now with recover more than 40% with a greater than 10-point improvement. These patients are in remission. Treat them like heart failure with reduced EF. The 4 pillars of stage C heart failure with reduced EF treatment. Here comes the heroes, the 4 pillars of guideline-directed medical therapy, GDMT, guideline-directed medical therapy for heart failure with reduced EF, class 1 recommendations. ARNI, sacubitril valsartan, prefer over ACE inhibitors and angiotensin receptor blockers, reduce mortality and hospitalization. Evidence-based. Number 2, evidence-based beta blockers, which are only 3, carvedilol, metoprolol, succinate, and bisoprolol. MRAs, mineralocorticoid receptors antagonists, which are spironolactone or eplerenone. These are the antifibrotic magic. SGL2 inhibitors, dapagliflozin or empagliflozin, foundational for all symptomatic heart failure, regardless of diabetes. Start them early, titrate aggressively, and watch life transform. This quartet of medication is game-changing. Clarifying stage B management. Stage B is pre-heart failure. Don't throw the kitchen sink yet. Example, patients with an EF of 33% but asymptomatic, they get ACE inhibitors or ARB or ARNI plus beta blockers to prevent progression. Full 4 pillars, especially MRA and SGLT2 inhibitors, are generally reserved for stage C unless they have diabetes, CKD, or the compelling indications where SGLT2 inhibitors chance for prevention. Precision matters over treatment, sometimes can cause harm. Heart failure with preserved EF management. SGLT2 inhibitors and GLP-1RAs. For heart failure with preserved EF, LVEF greater or equal to 50%, SGLT2 inhibitors have a strong class 2 recommendation to reduce heart failure hospitalization. In the obese heart failure with preserved EF phenotype, add GLP-1R receptors agonists like semaglutide from step a heart failure with preserved EF trial. It dramatically improves symptoms, ACCQ score, exercise capacity, and cause meaningful weight loss, up to 13% in trials. This is a paradigm shift for metabolic heart failure with preserved EF crowd. Diuretic stewardship. Diuretic are for euvolemia, not forever high doses. In heart failure with preserved EF, the therapeutic window is narrow. These patients are preload sensitive. Too much diuretic drops blood pressure and perfusion. Too little causes congestion. Precision titration using daily weights, symptoms, and exam is an art. The goal, dry weight without hypotension. The heart failure with improved EF, also known as the recovered heart. Heart failure with improved EF is the success story. EF improved from less or equal to 40% to more than 40%, but is not cured. The TREAT heart failure trial showed that withdrawing GDMT in these patients with normalized EF led to relapsing around 44% within months. Mandate: continue all 4 pillars of medications indefinitely. Is remission, not recovery. Protect the heart forever. Pacer-induced cardiomyopathy, classic iatrogenic trap. Patients get standard right ventricular pacemaker. EF drops from 55 to 30%. Now is stage C heart failure with reduced EF with desynchrony. Y pace QRS. Symptomatic management: upgrade to cardiac resynchronization therapy, CRT plus full GDMT. Many recover to heart failure with improved EF status, but again, stay on meds and CRT. Now we're gonna go over 20 cases about the specific staging and treatment. The metabolic patient. This is at risk stage or stage A. 52-year-old man with hypertension, diabetes type 2, a BMI of 34, is asymptomatic, has a normal echo with mildly elevated proBNP at 45. This is pure stage AA, metabolic risk, pathophysiology, inflammation, and future remodeling waiting to happen. The management, aggressive lifestyle, plus SGLT2 inhibitors for cardioprotection for whey glucose benefits. Prevent the transition to B or C on staging of heart failure. Now, the asymptomatic systolic dysfunction with the stage B. Athlete with incidental EF 35% on screening echo, no symptoms. He's classified as a stage B or pre-heart failure. Remodeling has started. Initiate ACE inhibitors, ARNI, plus beta blockers to halt progression. No full pillars yet, unless comorbidities dictate otherwise. Now, the post-chemotherapy monitoring. A breast cancer survivor post-anthracycline trastuzumab with an EF of dropped to 44%, still asymptomatic. Cardio-oncology, stage B, toxic cardiomyopathy. Star cardioprotective ACE inhibitors or ARVs plus beta blockers. Early to preserve function. Serial echoes are key. Now we have the asymptomatic hypertensive heart disease. A 70-year-old with poorly controlled hypertension, LVH plus left atrial enlargement on echo, but walks 2 miles daily, asymptomatic. Pressure overload, stage B, stage B staging. Aggressive blood pressure control to less than 130/80 is the best prevention against sliding into symptomatic stage C heart failure. The new diagnosed heart failure will reduce EF. A 60-year-old with new dyspnea and edema, a BNP of 800 and EF of 25%. This is the classic new stage C heart failure will reduce EF. Hospitalized or rapid outpatient start of all 4 pillars of plus loop diuretics. This is where GDMT saves life. Initiate ASAP. Post-MI, mildly reduced EF. Post-STEMI with an EF of 45%, mild symptoms. This is a stage C with heart failure with mild reduced EF. Ischemic, full GDMT, including SGLT2 inhibitor, ARNI, MRA, beta blockers plus high intensity. Statin, revascularization status matters. The classic obese heart failure with preserved EF. A 72-year-old woman, BMI of 42, hypertensive, obstructive sleep apnea, social dyspnea, LVF of 62%, BNP elevated for BMI. This is the obese heart failure with preserved EF. Inflammation and microvascular issues, stage C. SGLT2 inhibitors plus semaglutide, GLP-1 RA, plus careful diuretics, weight loss is therapeutic here. The success story, idiopathic cardiomyopathy EF from 20% to 55% on GDMT, now hiking symptom-free. Beautiful heart failure with improved EF. Stage C, continue indefinite full GDMT, do not de-escalate. Trend heart failure taught us a relapse is common. Acute decompensating heart failure will reduce EF. Stage C, flash pulmonary edema, RELS, EF of 25%, acute decompensation, IV diuretics, oxygen, stabilize, then initiate optimized GDMT in hospital. The end-stage refractory heart failure, stage D, multiple hospitalization despite max GDMT, EF 15%, low blood pressure, rising creatinine. This is stage D. Evaluate for LVAD, transplant, or palliative care inotropes. Cardiorenal syndromes in full effect, heart failure team involvement is critical. Pacer-induced heart failure will reduce EF and symptoms. Stage C. RV pacemaker EF dropped 30%, YQRS, NYHA 3. Iatrogenic dysynchrony. Upgrade to CRT plus GDMT. The CRT responder is stage C. heart failure with improved EF, same patient post CRT, and EF back to 55%, gardening again. Heart failure with improved EF success, maintain CRT and all four pillars. Transthyretin amyloidosis with symptoms stage C, 78-year-old man with carpal tunnel history, thick wall, low voltage EKG, positive PYP, heart failure with preserved EF phenotype, cardiac amyloid, ATTR, tafamidis plus specialized diuretic management. Diagnosis changes everything. Valvular driven heart failure with preserved EF stage C, severe aortic stenosis with dyspnea. LVEF of 60%. The heart failure is secondary to valve disease. TAVR or SAVR is the primary treatment. Fix the afterload. Case 15. The improved heart failure with mild reduced EF, stage C. EF from 15% to 42%, partial recovery. Still heart failure with improved EF territory. Continue full GDMT and titrate aggressively. The frail metabolic phenotype, stage C, severe obese, heart failure with preserved EF with diabetes, obstructive sleep apnea, breathless at rest, high BNP, aggressive decongestion plus SGLT2 inhibitors plus GLP-1RA plus CPAP, multifactorial attack needed. Early heart failure with reduced EF post myocarditis, but stage B, young patient post viral myocarditis, EF of 38%, asymptomatic. Is stage B, ACE inhibitors plus beta blockers to support recovery and prevent worsening. Cardiorenal syndrome type 2. Chronic heart failure with reduced EF with recurring creatinine rise during decompensation, venous congestion driven kidney injury. Optimize cardiac output and decongestion. It often improves renal function. Ischemic cardiomyopathy with stage C, multiple stent history, EF of 25%, akinetic, wall orthopnea. Scar-related heart failure with reduced EF, 4 pillars plus consider revascularization plus ICD evaluation. Hypertrophic obstructive cardiomyopathy, young woman with Hawcombe thick septum LVOT grading essential symptoms, beta blockers first line, consider mavacamten, myosin inhibitor for obstruction, avoid vasodilators. Every visit, you have to have a summary checklist. Check EF, stage the patient, the ACC staging system, and NYHA class. Stage C is permanent. Recovery is remission, requiring lifelong protection with GDMT. This clinical matrix will make you a better clinician. Review the reference of Universal Definition of 2021, the heart failure guidelines, treat heart failure, step heart failure with preserved EF. Thank you for watching Cardiology 305. Drop your question in the comments, subscribe for more advanced cardiology, and go apply this knowledge. Life depends on it. See you next time. And remember, this is only for